I want to go over, especially for everybody here, but especially for the residents, some of the epidemiology of poverty. It's actually very complicated, and we can dive into it at other times, but then understand the relationship between poverty and health. We'll talk about a model for that, including ACEs, adverse childhood experiences, and other things. And the relationship between poverty and child health outcomes, the things that as doctors we're really trying to address, are very significantly impacted by poverty. We'll go over that. And then I want to go at the last part of the talk on poverty on policy level. What can we do as a country, as a state, as a community? And then ultimately at the end, Karen's, I think, watching this remotely, Karen Sketsina, I borrowed a slide from her based on a new program that we're starting in our clinics. So a lot of what I'm going to be saying, we're really going to be trying to address in a very applied way in our clinic. So I hope that you guys can make that connection. So definitions of poverty. The poverty is set by the federal government. There's a poverty level. It's called a poverty line. If you're a family of four, it's 24,600 in this year, and a one-person family is 12,000. Low income is another term you'll see. That's twice the poverty level. And most of the programs that we think of as, quote, poverty programs like Medicaid, food stamps, close to it, use the low income criteria to qualify. And if you look at the economics of poverty in our country since the 1960s to today, people that are at 200% of poverty, which means a family of four, $48,000. That's not insignificant. That's close to the median income of our country. Half of the people in our country make about $56,000 a year as a family. They have the buying power of the people that were poor in the 60s. So the buying power has eroded for people that are poor. Extreme poverty is considered below 50% of the poverty level. This is a graph that shows on the top, the number of people in our country that are poor, and here's the percent of all people in our country that are poor. And you can see over here in the last 10 years or so, it's hovered around 15 to now, and last things we've had a decrease in the last couple of years in poverty rates, but about 15% to 13% of total people are poor. And of course, as our population grows, the rate stays the same, the number increases as well. What percent of children do you think are poor? Let's say it's 13% of all people are poor. What percent of children are poor? More than that? Less than that? Remember that there's elderly in there, there's adults in there. So what percent, do you think the percent of children that are poor is higher than 13%? Yes, okay, it is. So here's a very interesting graph that shows from 1959 to the present, last year, poverty rates by age group. The blue is the 65 and older. The green is the middle age, 18 to 64. Oops, I'm still middle aged. How do you like that? That's cool. And then it's under 18 is the red. What did we do? Look, this is one of the most impressive things. Look at the poverty rate in the over 65. Back in the 50s, it was, a third of elderly people were poor. Now it's about 9% are poor. What did we do in this time to dramatically reduce the poverty in the elderly? I heard it over here. Social Security. 1965 is when we passed Social Security. We also passed Medicaid in 65, Medicare in 65. It was called the Social Security Act. So this is one of the most dramatic examples of how a public policy at the federal level can dramatically affect poverty. Interesting, look what happened to kids. Look what happened to kids. At that same time, we kind of drifted up. Well, our families drifted up. And so the poverty level for children under 18, if you disaggregate this, it's almost twice as much as the poverty level in the elderly, and a good 60-70% higher than the non-elderly adult population. Just to go a little bit more into the epidemiology, this is the percent of children in our country of the total population, 23%. Interestingly, in Northeast Tennessee, what the percent of children in the population is lower. It's like 20%. So we have actually more elderly and fewer children in our region. But you can see that they're overrepresented in the very poor, the near poor, or the low income, and the above poverty. So they're underrepresented in above poverty. They're really significantly overrepresented in even the very called extreme poor in our country. And actually, if you look at this by age, I don't think I have a slide for this. Which families are the poorest? The families with older children or the families with younger children? Younger children. So the families with children 0 to 5 are the poorest of the groups of families in our country. So does that make sense that families, some of it makes sense because they're young, they're starting out in their career, they don't have as much money or wealth, but to allow our youngest children, and we'll go over some developmental issues, to experience the worst poverty in our country, when that's the age when they're acquiring most of their cognitive abilities and developing the most rapidly. From a developmental pediatrician, from a developmental perspective, that doesn't make a whole lot of sense. And in fact, a lot of countries have agreed with that and started to address poverty in young families. This is just a slide that shows you the dramatic differences in family income. And I will say family income means who lives in your household, who do you consider your family, and you count all the money they make. So it's not just the primary wage earner. If you have 2 people in your family working, you count both of those incomes. And so look at the huge difference between a high school graduate and a bachelor's degree. So, and if not being a high school graduate or just being a high school graduate is a tremendous disadvantage in terms of ultimate family income. So education is very important. This is a slide from our region. This shows the different counties. This is the national poverty rate. This is of 2014. It's gone down. This is national child poverty rate. It was as high as 22% during the recession, and then it was coming down. It's now down to about 18%. But in 2014, it was about 21%. And so when you look across our region by county, Washington County, which we're in, is not that poor. It's not poorer than the rest of the country. But almost all the other counties in Northeast Tennessee are much poorer. And look at Carter County, Cook County, Greene County, significant poverty. And remember that you got to double those numbers to get low income. So 80% of families from Carter County are low income. This is just another, there's a very important thing going on in our country, and a lot of sociologists have documented it. That we're having less segregation by race and more segregation by class or income. Class is more than just income, but it also is education and your job. But we're having more segregation by class, and it's but it is more prevalent. This segregation. This shows the percent of children living in high density poverty areas. So a high density poverty area means more than 30% of the children or families in that area are poor. And with high density poverty areas, what do you get? What do you get in high density poverty areas? Drugs, crime, deteriorating housing, schools that are not up to snuff. So and that's what we're going to talk about, this constellation. But this is definitely, although we have less segregation among racial groups in the upper income, middle and upper incomes, still the minority races are still much more segregated and into very high density poverty areas. White, non-Hispanic white is down here, and very few of non-Hispanic whites are in high density poverty areas. So there is a combination of both racial and income segregation going on. Another measure of poverty is not just are you poor right now, today, but how long have you been poor? And you can see that 10%, so we said about 18% of kids are poor now. When this was done, probably 20%. So about half of poor kids stay poor for a long period of time. About 10%. About 10% are poor for less than longer periods of time. But there's, again, huge racial differences in persistence of poverty. Lifetime poverty, meaning following people over their life. Were they poor when they were children? Are they poor when they're adults? You can see the numbers. It's persistent lifetime poverty is much more common in minority populations, but still a third of white children and still a majority of poor children are white in this country. So a third of people who start out poor stay poor. And this is actually a very big issue in our policy right now. This idea of moving up and opportunities to move up classes. We're now well below the other developed countries in the ability to move from poor to non-poor. So our rate of intergenerational poverty or staying poor as you get older has increased in this country. That's one of the concerning issues we have is, are we the land of opportunity? We were, absolutely in the 50s and 60s and 70s and 80s, but in the 2000s, we are not the land of opportunity when you compare us to Germany or France or England. So American Academy of Pediatrics decided that poverty, through a lot of lobbying, decided that poverty was a major, major threat to children's health. So they decided to do a clinical report and a policy statement. I had the opportunity to participate in the clinical report. The clinical report was more focused on how does poverty affect kids? Why does it affect kids? What are the mechanisms for poverty and having a negative impact on the health, development, and welfare and outcomes of children? The policy report was more on what do we do about it? What do we do about it as a country? What do we do about it as a pediatrician? And we'll go through all that. In both reports, we use what's called a social determinants model of health. And what is a social determinants model? It says that your health as an individual is a function, and this is actually an adult model, so it doesn't have a family here, but the family, your individual lifestyle factors, but social and community networks, as well as even larger social economic factors play a role. For example, if you grow up in an area where there's no clean water, that affects your health. That's not a decision you made. It's not part of your family structure. It's a part of the community that you grew up in. And as we knew from Flint, Michigan, and I've heard now 3,000 other communities in the United States have lead contaminated water. There are many important things like the quality of the education, employment opportunities, all these things that really impact the health and welfare of families, which impact the health and welfare of children. So this is the social determinants model. It's as opposed to saying that your health is a factor of just your genetic endowment and just your behavioral choices. And we know as pediatricians, the health of children, when we're talking about mental health as well as physical health, is dependent a lot on the parental behavior and the parental resources. So this is a very important model for pediatrics. We practice it all the time, and we think about it all the time. We're the ones that really interact with social services and WIC and all these other support services because we know that this social community model or social determinants model really has a really important impact on kids' health and welfare and their ability to grow. So I used this picture because we're going to now talk about the environment of poverty. We've already mentioned that when you have high density poor areas, there's a lot of other factors that come to play. And this is just a picture that shows kids playing in the street. They don't have a matter of fact, in clinic, I was talking to a patient, they are overweight, and we were talking about the ability to go to the park and play. And they live in, I always forget the name of this community, but it's north and kind of a little bit east. There's no parks there. So in our area, think of how many parks and recreation areas there are. One of my children just moved to Cincinnati. They can walk to 3 different parks from their neighborhood. Can we do that? No. So there are environments of poverty, the housing is affected, family affected, and I'll show you some of that data. And it's really called cumulative risk. So it's not a matter of poverty itself being the factor that drives these things, but all the other risk factors you see up on the screen there, that you see this in clinic, right? You see families that have these issues. And so it's exposure to smoke, that's very prevalent here, exposure to other toxins, maternal deprivation, meaning, and it also mentions distressed, depressed mother. but mothers that can't attend to the needs of their children in the most stimulating way because of their own depression or their own stresses or their own relationship issues or maybe their housing issues. These are all things. There's one thing that they have a term called cognitive bandwidth. Anybody heard that term, cognitive bandwidth? So we all have a fixed cognitive bandwidth. And I can attend to my children, attend to my spouse, attend to my work, as long as I don't have lots of other things going on in my life. But if I'm having problems with drinking, or I'm having problems with work, or I'm having problems paying the rent, or I'm having problems in other areas, that uses up some of my bandwidth. And I can't attend at work, I can't attend with my family, I can't attend with my children as much. So it's a relative thing. So families that are faced with these factors, unsafe neighborhoods even, when we see people who say, you know, why do you let your child play on the electronics, 5 hours a day, 7 hours a day? Well, if there's no safe place to pay and they have to work, there are factors that they really have to basically allow their children to be self-entertained because they don't have the cognitive bandwidth or the resources to do that. So a lot of times we blame those people for not doing that. They should know better. But there is a fact, all these factors come into play, and many of us don't have to experience all these things. So oftentimes it's hard for us to identify with families who are experiencing those things. And I think one of the key things in your training is to learn to identify with those families. You're going to be in the top 3 or 4 or 5% of earners in the country once you become doctors. But to maintain that connection, to understand these factors so that you can have empathy and really put yourself in their place so that you can help them solve their problems in the context of their lives. So here's some of the data. This is from a lot of different studies. That these are these are called odds ratios or risk ratios. So children growing up in poverty are 6.8 times more likely to experience abuse and neglect, almost 6 times more likely to have parents that get divorced, 3 times more likely to have a birth as a teenager, twice the rate of maternal depression, experiencing violent crimes in your neighborhood over twice, multiple moves. You can see this. So these are kids growing up with these kinds of risk factors, these kinds of experiences. And how does that affect them? So Andy Gardner, who was here a year and a half ago or so, he wrote the report that developed this model that we are now talking about as pediatricians. We now understand that the environment that a child grows up in impacts not just their social circumstances, or not just impacts their opportunities, but impacts their biology. And we'll go through why it impacts their biology. So this is called the ECO-BIO-DEVELOPMENTAL model. And because we follow children through their life course, its life course is right here, the ecology or their environment impacts their biology, and we'll go through that more of it. And together these two promote or impair development. And children are on developmental trajectory. I have a slide that I didn't show here, but negative influences can impair their trajectory. And if you impair the trajectory early on in a vector or early on in their life, that trajectory can be significantly worse than it would have been had they had the adequate or supportive environment. So this is based on the stress model. People are pretty familiar with this now. It's been talked about a lot, that we all have stress. We have good stress. We have some positive stress, like studying, getting all psyched up to study for a test. What happens, we'll go over the physiology of this, but you focus, you do it, the stress resolves. That's encouraging. In children, learning to pick up your room is a stress. Having to go to school is a stress. But those are positive stressors. I mean, Matthew can go on at length about the positive aspects of stress in our life. We all thrive on stress, actually. But if it's toxic stress, which means it's prolonged, it's in the absence of supportive relationships, that's when it starts to have a negative impact, both physiologically and genetically, as I'll show you. So this is kind of the stress response model. This is the hypothalamus, the anterior pituitary, adrenal cortex, and with any kind of stress, our cortisol levels go up. if they stay up for long periods of time, cortisol impacts a lot of things. It impacts your brain development. It impacts the immune system. It impacts lots of things that affect how you develop. And one of the most important things that it impacts, well, here's the model. I'm sorry, I forgot that we had this model. So, and we'll go over a little more of this, but chronic stress also increases, epinephrine and these other neurotransmitters that dramatically impact the architecture of the brain. Oops, let me go back. So childhood stress, normal stuff, these things go up. It does impact maybe slightly, but if they can get reassurance, calm, if the stress can resolve, then it's fairly positive. But if this just keeps going on and on and on, then this is called toxic stress. And that's where you experience, and you see families who have ongoing addiction problems, chronic housing instability, family violence, disruptions in families. That's chronic stress for the kids. The kids don't show it. They're still that's why we're pediatricians. They're happy. They're laughing most of the time. But there's lots of other signs we can pick up on in their behavior and other things that show that they're experiencing chronic stress. Most of the time, if you have a 2 or 3 year old that's out of control and you look at the history, they have actually absolutely experienced chronic stress. It's not just a parenting issue. It's a whole milieu of experience. And unfortunately, their brain is being impacted by this. So this is from the Center on the Developing Child, which coined the decade of the brain, which really gave a lot more attention to the developing child, which has helped us as pediatricians make a case for policy issues as well as health services issues. And you can see from persistent stress, these are 2 same-age children, 3-year-olds, extreme neglect. This is an extreme case where the brain literally doesn't develop if you're neglected, extremely neglected. We saw this in the orphanages in, I blanked on the country, Romania. In the Romanian orphanages, their children were just stunted because of neglect. And we can see this in severe cases of neglect. And it causes reduction in brain growth, development, pruning, or branching. So there's a lot of impact on the architecture of the brain. This is actually a very interesting study, and more of this data is coming out to look at the physiologic impact on children's development as they experience stress. They followed children over the course of about 3 years, and they did serial MRIs. This is obviously a consent study. They followed them typically between these ages, 5 to 37 months. And they selected them based on their socioeconomic status. So the blue are poor, the red are kind of middle income, and the green are higher income. It resulted in, as you follow them by socioeconomic status, about a 10 to 15% difference in brain growth, literal brain growth. Mostly the cerebral cortex, the kind of the processing centers of the brain were affected. So that we have some pretty increasing with functional MRI and other things. We have more and more physiologic and anatomic data that stress impacts children in very significant ways. This is just a slide that I use in I think we had it in the transition talk, just to remind people that the brain is still developing until the mid to late 20s, especially the prefrontal cortex, which is the executive functioning of the brain. And so a lot of what we see in the kids that are chronically stressed is that their amygdala, their hippocampus, their primitive cortex of the brain, which is the fight and flight, which is go, 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 fight, 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 that is overdeveloped. And the prefrontal cortex, which is the restraint, considering, making deliberate choices, really moderating that fight and flight, there's an imbalance there. So again, when you see 3-year-olds that are just wildly out of control, part of that is physiologic. They're on, and we'll talk more about this when we talk about trauma, but they've been traumatized. Their adaptive response to trauma is to fight back. Unfortunately, then they take that adaptive response to trauma and apply it everywhere in their life because they can't really discriminate. So when they're fighting in their school or they're fighting with their peers, that's not very adaptive in that setting, but it was adaptive to them and that's what they learned. So that's how they behave. But there's another mechanism here which you're learning more about. It's called epigenetics, where it's not just the genetic endowment that we have, but it's also the expression of our genes, which is we're learning is an incredibly complex and very sensitive to environmental influences. So epigenetics is this new science to say what influences whether a gene is turned on or off, or combinations of genes interact to be turned on and off. Genetics used to be Mendelian. When I was in medical school, it was like pretty simple Mendelian genetics. Now it's fantastically complicated, and epigenetics is added to that. So kind of putting these two things together, when you experience both positive or negative stress can do this. You get positive or negative epigenetic changes which affect, or positive or negative brain development. That ultimately impacts your ability to succeed in school, or your behaviors are oftentimes significantly influenced by that. And that actually then is a feedback loop. So when you have kids that are really out of control behaviorally, what kind of feedback do they get? Pretty negative feedback. So they're told, they get into this mode where the only way they can get attention in their environment they've learned is to create trouble or bother people or do really sometimes really bad things. And they get negative feedback that you are a bad kid and we need to discipline you or punish you. So it is unfortunately a very vicious cycle. But the new things that have come up in the last 20 years is that it's not just behavior, it's not just learned behavior. Some of this is rooted in physiology, in anatomy, and the neurochemistry of our brains. So this is just a slide I'll show you of the developmental trajectory of sensory pathways, language, and then higher cognitive function. I think this is an amazing slide that shows this is preconception. Birth is all the way through the middle of the slide and then up to 19 years of age. So much is going on developmentally in the first year of life that stimulating them, the serve and return, the nurturing response of the mom and the father or the other caretakers is so incredibly important to the development, the neurodevelopment of that child, the formation of synapses. And what gets stimulated gets formed. If you don't stimulate something, it doesn't get formed. So one of the most important take-homes of this is the culture or environment of poverty that impacts kids is really having its impacts so early that we need to get on this. To intervene when they're failing in 3rd grade, the horse is out of the barn. So we need to intervene early. This is another example of that. This is a study where they followed families who were poor, middle class, high income, and they literally counted the words. They monitored the language that was used in the household, and they looked at the vocabulary of the infant. So this is an observational study. They spent hours and hours with these families over time, and they saw that over the first 3 years of life, there was this growing gap of vocabulary. But not just vocabulary, experiences, kind of the understanding of the world. So, and they estimated that by 36 months of life, the poor kids who had a vocabulary of under 400 words compared to the high SES kids who had a vocabulary almost 3 times as much, they had heard 30 million fewer words. 30 million fewer words. And why is that? Think about our families. They're distracted. They're not that verbal themselves. They put the child in front of electronics. They don't hear. And so this is an incredible problem that we have, and something that is one of the reasons why our Reach Out and Read program is so important, is to really encourage the families to read to them, just to play with the books, to talk about things, to stimulate their language. Here's another slide that just shows that poor kids, here's poor kids here, non-poor kids here, are really at a significant, this is the ratio of poor to non-poor, meaning poor kids experience between 2 to 4 times higher rates of obesity, asthma, serious emotional behavioral, grade repetition, high school dropout. The factors are anywhere between 40, 50% higher to 300 or 400% higher. So there's many studies. This is only just a few. This is from a summary article from Academic Pediatrics, but there's hundreds of studies looking at the impact of poverty on children's growth, development, behavior, you name it, and ultimate adult outcomes. And so one of the big things I think you guys are hearing about a lot more is the ACEs. So I won't bother. How many people have heard of the ACEs study? Pretty much everybody. Good. So ACEs was started in Southern California. I don't know if people know this story. ACEs was started there because they had it wasn't Kaiser, it was one of the other health systems. Dr. Fletty had a weight loss program for adults, actually a cardiovascular risk reduction program. So you're having 40, 50, 60-year-old adults who are having cardiovascular disease, and he was trying to help them reduce their risks. And he could not figure out why there were some people that really were responsive, and some people were not responsive. And there were some people that responded and then rebounded and did poorly. And so he started looking at their past and just doing clinical histories. He figured out the ones that could not reduce their risk factors, like smoking, drinking, all kinds of other risk factors, were the ones that had experienced trauma in their life. And so here are the rates of trauma. And now we have national surveys. It's a survey for National Survey for Children's Health, which is done state by state, produces rates of ACEs now. And so this is for Tennessee. This is the percent of children in Tennessee that have experienced divorce. A third of the kids experience divorce. Almost a third experience substance abuse in their family. That's incredible to me. Emotional abuse, violence, mental illness, physical abuse, sexual abuse, incarceration. Over 10% of kids experience some parent that got incarcerated. So there's these ACEs that are going on, but they're also cumulative. And there's now an expanded ACEs list, by the way, that includes just poverty is on the ACEs list. About half of kids report that they did not experience ACEs. By kids, I mean parents report when they were children. That's how it's done. We are now starting to do surveys of adolescents to ask about their early childhood. But about half of the population's experience an adverse childhood experience. And there's this group of, a fifth of the population that experienced multiple ACEs. And I'm going to show you some data about adolescents. But these ACEs have a very significant impact downstream. But just to show you how are we doing with ACEs in the country, red means we're significantly above the average. So blue means you're significantly below the average. Green's kind of in the middle. Green and brown are kind of in the middle. So we have significantly more ACEs in our population compared to other states. If you drew a map of poverty, it would overlap pretty significantly with us, not exactly. But there's a big association between poverty and ACEs, as I'll show you. And this is the next slide. So this slide shows you, based on this National Survey of Child Health, what proportion of families had no adverse childhood experiences, what proportion had one, and what proportion had two or more. And the blue are the poor, the green are, they didn't have poverty statistics on these families, but they used insurance as a proxy. So if you have Medicaid insurance, you're at 20%, or you're at low income. And you can see that for the low income families, their rates of ACEs are more than double the people with private insurance. I need to move quickly here. So ACEs are associated with almost any adverse outcome you can imagine. This is early debut, sexual debut, teen pregnancy, teen paternity, and this is 0 ACEs all the way up to 4 or more. And it's this isotonic relationship. The more ACEs you have, the more likely you are to have bad outcomes. I'm going to skip that one. This one is a complex slide. You don't have to look at it, but the point is, these are all the ACEs over here. This is self-harm in adolescence, suicide ideation, and suicide attempts. And the odds ratios, you can see, are all above 1. They're 3 and 4 times as high for kids that have experienced any kind of ACE to have more suicide ideation, more self-harm. So there's a lot. And so when you look at kind of the downstream effect of ACEs, which are again concentrated in poor populations, all these different health effects are downstream. I think one of the things we're learning is that as pediatricians, and child health advocates and child social service providers and communities, if we can address some of these ACEs early on, which are, again, highly associated with poverty, then we can have a significant impact on these downstream adult health problems that we're seeing. So what can be done to address? So this was the policy statement by the American Academy. I will skip this. That's more of the ecologic model, but it'll take a while. So this is a international comparison of poverty between the United States and other countries. This is child poverty. And these are comparable statistics in terms of trying to equalize the differences in currency and that sort of thing. Norway and Germany have the lowest child poverty, and here's the United States over here. And this again, if you look at all the developed countries, there's about 40, we're not at the very bottom. Mexico's in there, it's below us. But we are worse than many countries. This is a very interesting slide that shows, if you just look at the economy and how it produces poverty, and you take away, you don't include the income transfer programs, which I'll show you in a second. What's the poverty rate? So these are up here on the top of the arrows are the poverty rates for these countries before you add in social programs, I'll just call them. Here's the United States. So we have a poverty rate that's about 30% with no social programs. Ireland has this poverty rate 37% with no social programs. And here's the impact of their social programs. So these countries have an economy that generates fewer poor people. Not social programs. These are what we call, many people would call these socialist countries, but that's their economy that produces lower poverty than our economy does. But then our income transfer programs and our non-income transfer reduce poverty, and there are some countries like the United Kingdom had a major initiative to reduce child poverty, and they reduced it significantly. They were about 20% before they had the initiative. Now they're down about 10%, whereas we're at about 18%. So other countries have done a lot more, either in their economy or in their social programs. What are social programs? Government programs that reduce poverty, and they have a big impact. Without them, our poverty rate in kids would be about 30%, and with them, our poverty rates are about 14%. So when people say welfare programs don't work, welfare is a general term. They do work. They actually reduce poverty very significantly. And here's different welfare programs or income transfer programs. One's the Earned Income Tax Credit, which is being talked about right now with our the tax bills before Congress. So the Earned Income Tax Credit and the Child Tax Credit are probably the biggest impact on child poverty in the country. And what that does means if you're poor enough, you can get a tax credit so you don't have to pay tax, and that increases your disposable income. And there is a tax credit for children. And so if you have children, you can get a tax credit. It's $1,000 off your taxes. So that's an extra $1,000, to your family. There's also these food stamps. We know about food stamps. They significantly reduce, these are the number of kids, all ages, or the number of children that are brought out of poverty, above poverty by these programs. So these programs bring a lot of people out of poverty. Housing assistance, SSI is interesting. Temporary assistance for needy family is the new welfare program. It's only affecting about 2% of families now. So it's not really raising a lot of families out of poverty. I won't go through this slide, but just to say this is a slide from the American Academy of Pediatrics. And one of our policy statements we're advocating is to increase the Earned Income Tax Credit and increase the Child Income Tax Credit. These are the benefits. They've done a lot of studies to show that families that benefit from the Earned Income Tax Credit have children graduate from high school more. They're more likely to go to college. Their future earnings are higher. Their ultimate dependence on the social safety net is less. So these investments in early childhood pay off dramatically in downstream costs. And this is a slide showing that. James Heckman is a Nobel Prize winning economist who has focused his work on the impact of child support programs. By support, I mean anything from education, social support, family support, home visiting, all the things we talk about, and I'll talk about in about 2 seconds, he's studied. And he's found that the return on investment, the earlier you go, this is the return on investment, and these are different age groups. The earlier we go to invest in children, the higher the rate of return on investment. I don't know if those of you that have investments, but a rate of return is phenomenal if you can get 6 to 8%. If we invest in prenatal and perinatal and early childhood, the rate of return is about 13% per year. It's an incredible investment, incredible payoff for investment in social programs for kids. When you get out here in high school, and then post-school, like job training or intervening in school, the return on investment is less. And what we're saying as pediatricians is that's because the brain's already been formed. That's because it's less plastic. It's still forming, but we want to intervene when the child is most receptive to the positive influence of these programs. This is a complex slide too, but the blue shows the impact of early childhood interventions on lifetime earnings. The red is the official education, like kindergarten to 12th grade. So for some of these things, like future learnings, early intervention has a bigger impact. These are some behaviors, actually, like smoking, obesity. And so early interventions in early childhood have significant future impact on those as well. So what we're trying to say as a country is that we should be investing in young children. And I'll just mention, this doesn't come out too well, that what are we doing here at ETSU? So this is a flow chart that Karen Scatina put together for an application to the state, which was called Healthy Brains. The state was giving out grants to develop programs to build healthy brains. And now, based on what I've said to you, maybe you knew it before, but now you understand what we mean. Improving the social environment of children will help their brains be healthier, help better neuroconnectivity. And so this program, because we know ACEs has a major impact on that, focuses on ACEs as well. And so we are going to institute a program in our clinic. We already do some of this. Our clinic has been, Dr. Jaishankar and Mills and Toole and Gibson and others have taken the lead to initiate Reach Out and Read and the Read and Play program. All those things, you may not get that as a resident, but all those things are really designed to enhance the child's neurocognitive development. And they're evidence-based. So what we're going to be doing is, and maternal depression, huge impact on children's development. So we were early on in initiating the Edinburgh screening. So we now have a program where we're going to be actually screening for ACEs. And we're also, one of the most important interventions that you can make that pays off manyfold is improving parenting. Not to say that they're necessarily bad parents. We can all use help in how to be better parents. But if we can intervene early and help parents learn to interact with their children, read with their children, positive discipline, that'll dramatically improve the development of their children. So we're going to be screening for ACEs. We're going to be doing, emphasizing heavily our Reach Out and Read program, our Read and Play, intervening on the women that have screened positive for depression. And then also, so the women that screen positive for ACEs, we have a kind of referral resource, both the HUGS program and the Families Free program, to get those families into some resources that can help them address those ACEs through more intensive services. And the ones that are less than 2 ACEs, and the ones that are 2 and more, we are developing kind of a short, rapid parenting intervention that we're calling enhanced well child care. I'm calling it enhanced well child care. There's another name for it, but it's Baby Steps to Success is the program. But I wanted you to understand what we're trying to do, because this is really getting at the root causes, not in terms of what we can do as pediatricians. What else can we do for the last 1 minute as pediatricians? We can advocate for programs that relieve poverty. I've tried to make the case, there's lots more data we could show you, that social programs impact family poverty. it's not just the economy, it's also public policy, community policy, the availability of parks, investment in schools, investment in early child care. In this region, there's a thing called Head Start, which is federally funded. We have about 8,000 children in this region that qualify for Head Start. We have 1,000 children in Head Start. 7,000 children are not in Head Start that should be in Head Start. We have no early Head Start. I don't know why. We've talked about this with my education colleagues. We've never applied for the money. But so the availability of actually high quality childcare in this region is abysmal, to be honest. And other communities are really taking this initiative. Southwest Virginia, in Tennessee, only 19% of children are in pre-K, which is school-based pre-kindergarten. In Southwest Virginia, Virginia supported that 95% of the 4-year-olds in Southwest Virginia are in pre-K. About 20% of ours are. So there are things we can do as pediatricians to say these things are important for developing children. And we need to advocate for them in our own healthcare system, in our own clinic, but even beyond that. And that's what our advocacy rotation is trying to teach you, and what we're trying to teach you throughout this residency program. And honestly, if we can, as pediatricians, impact our local environment, impact the policies toward children, based on many studies, that's going to have more of an impact on the health and development of children than our own services. That's kind of humbling to think about, but it's true. So, and I do want to mention very briefly, this is my last slide, that Kim Hale from the College of Education and I are trying to bring to this region what's called Transforming Early Childhood Community Systems. We've been seeking funding for this. We're hoping that we can get it. But it's basically looking at kindergarten readiness across all children in this region. There's 325 kindergartens in the 8 counties of Northeast Tennessee. And basically mapping how children are doing. Are they ready socially, emotionally, cognitively for kindergarten? And then going upstream to try and address that through all the things we're doing in clinic, whether it's screening for maternal depression, screening for ACEs, doing parenting, home visiting. So I hope that with this merger and with bringing our communities together, that we can really start to enhance the service delivery system for young children. I give a talk on this, it's a whole talk, but when you look at the service delivery system for young children, it's much more disjointed than the service delivery for older children. So we have a lot to do to improve that. So my last slide is, equality is not the same as equity. So here's equality, everybody gets the same. But does that make everybody reach their potential? No. Equity means we provide the services based on the need of the individual to help everybody achieve their potential. And that's where I hope we can go in this area and go as a country. Thank you very much. I did finish before 1. Are there any questions that people have? Yes, Tiana. Oh, really?
Only servicing 72 of the 8,000 children that need services, but
An early Head Start?
yeah, 6 weeks to 3 years of age.
So Head Start goes from 6 weeks to 3 years of age? So there's some funding for early Head Start, very limited in this region though. And as you learn, the earlier you go, the earlier you can intervene, the better. Yes, Matthew.
Do we know, what, so child poverty is pretty broad in terms of all of the different factors, like you were saying, the cumulative risk that goes with that. Do we know what factors are at the top there, like the most impactful factors that go along with child poverty that influence outcomes? Or is it more of, it's hard to kind of tease apart those?
Well, no, that's a good point. A lot of the ACEs work has really almost treated every ACE as the same. And obviously sexual abuse is much more impactful than divorce even. But so there have been some work to look at some of those influences. What's interesting though is when you do that, there are influences at the child level, at the family level, at the really, micro community level, and the social level. So, and there's a dynamic interaction between them. So it's not a simple mechanism, but I think the ones that we all know, kind of like the more abusive, severe neglect, and sometimes when people are counting these things too, the measurement is not precise. So someone who's been neglected, there's both mild and severe neglect. So it is hard, but the ones that disrupt the bond between the mother and the father and the child through abuse, neglect, divorce, those are the ones that have the most impact. But even things like moving can disrupt a child's world and have a very significant impact on a child's developmental trajectory. Yes?
One would imagine, even with the national dialogue on it now, that drug use and drug abuse would be kind of a huge factor in our area at least. I think it's a fairly complex situation, given that there's drug use and then maybe the child is actually taken away from its family, and there may not be any maternal bonds at all, but does actual foster families do more for that child's health and development? And would you comment on that and how you're looking at it? I saw some of the older studies didn't have the drug use piece there at all,
Right.
Listed as a factor. And could you comment on how that might impact?
Well, one of the comments I would make is, for me, the upstream or the root cause of our drug abuse is some of these ACEs and some of the trauma that the child has experienced early in life really leads to a lot more likelihood of, with other stressors, of choosing to use alcohol, drugs in excess, and that sort of thing. The question of whether or not, are we doing good by removing a child from the home of a family that's maybe neglecting them or abusing them, it's really hard, because studies that have shown that it is a positive influence are usually studies that have had much more structure to the foster care system. But what really plays out oftentimes, especially for the kids, when you remove a 3-year-old who has lots of behavior issues, or God forbid a 13-year-old, they're more likely than not going to bounce around between multiple placements. And even though they may get a very good placement eventually, that mobility, those disruptions, I think we really struggle to know whether removing a child is, and that's why there's been a huge push in the last 20 years to keep children with the family, to provide supports for the family, because we do kind of think that keeping them with a family that's struggling or dysfunctional with adequate supports is probably better than putting in a system where we know there's going to be a lot of moves and disruptions. Yes, Ted?
Having practiced through these years you're talking about from the 70s on through, there's core problems that you can go back to, and the vast majority of what we're seeing here is actually a cultural problem more than anything else. You have a breakdown of the family unit. You went from a rare single-parent family to a common single-parent family.
Yeah, like a third.
Okay, you went from a rare situations where the parents were by themselves, they had family groups. So now that's very stretched and all kinds of not support. You went from a circumstance of where work and education were held up as very high things to go to a situation of what can I get through the culture. And there's a tremendous number of cultural changes that have occurred, and that is a result of what you're seeing with the kids now. Statistically, the answer is if you have more kids, you're poor. So don't have kids so you won't be poor. But we know that's not the basis of it. The basis is the vast majority of it, 80% of what you're seeing is cultural. And you can't, until you change that cultural approach, until you change the purpose of marriage as a union, and the purpose of that union is successful offspring, and the purpose of successful offspring, of course, is good life. That's not going to change. And so what you're seeing is a result of what happened back in the 70s of support systems being shattered, and you're holding up single parents as a model, as though that's not the model, and you're holding up all kinds of aberrant behavior as the model, and it's not the model. You're seeing some of that now. So we can do a lot as physicians, but individually, we can do a lot more as we talk to the patients and to the parents. Programs are really good, but when you pull the kid out of the house and put them in daycare, and that allows mama not to go to work, or allows dad not to go to work, or it allows other things to occur, then that's what the problem is. There's accountability.
Well, this is part of the debate we're having as a society, and it is a very complex. It is true that if you look at poverty rates, a lot of the factors driving poverty rates are the increased percentage of single-parent families. The poverty rates are much higher in single-parent families than two-parent families. But I think that there's a complex interaction between the economic and social forces and then the moral fabric or moral values of our country. And to say that it's one or the other, I've emphasized the more policy factors, but I absolutely think there are moral and ethical issues going on in our country that are changing how we see things. Some are good, some are bad. And some are driving poverty, but there's also a lot of policy issues that are driving poverty. And some of those policy issues are putting stresses on families. For example, the new welfare system is you have to work to get that. But they do provide daycare. So they're not providing daycare for the mom to sit at home. They're providing daycare for the mom to work. So there's, anyway, people are having to leave. Oh, yes, Jackson.
Speaking of policy issues, just FYI, tomorrow is an official American Academy of Pediatrics Day of Action. The CHIP program, which helps kids who fall between the cracks of insurance, has expired 2 months ago. That's the first time it's expired in over a decade. So the AAP is asking folks to call their senators to support the CHIP program. Takes less than 5 minutes. Put them on speed dial on your phone. It's very easy.
Very good. Thanks for mentioning that. Okay, thank you very much.